Good evening, everyone. You all are welcome to the fourth Senior Registrar Forum of the Year organized by Sri Lanka College of Internal Medicine. Today it is about ECG. Before starting, first of all, I would like to invite our President, Dr. Ganaka Senaratne, for a brief address the audience.
Thank you, Priyamali. Hope you can hear me and see me.
Yes.
Right, thank you. Good evening, everyone. So, SR Forum we have established to support our SR's professional development so that they could become a competent, confident and a compassionate internist one day. That's the aim of the college, to support their professional development. So I'm really happy to hear that this is the fourth session. We'll be having more in time to come. I would like to thank Priyamali for energetically and compassionately leading this project. And my profound thanks goes to Prof. Namal Wijesinghe, Professor of Medicine, my good friend. Namal, thank you so much for doing all this amidst your all busy schedule. So without taking much, take the lessons from Namal so that they can practice very well and enhance their clinical excellence. Over to you, Priyamali. Thank you.
Thank you, Ganaka. Just to explain about this, this is just not a lecture. It is here, Professor Wijesinghe want to do it as an interactive session. So we have actually unmuted all our senior registrars, so you can participate while having the discussion to have a fruitful interactive discussion. So let me introduce the speaker. So it is privilege to introduce my boss, Professor Namal Wijesinghe, Dean, Faculty of Medicine, General Surgeon, Kotalawela Defense University, and he's a Professor of Medicine. Without taking much time, may I invite Professor Namal Wijesinghe to deliver his lecture. Over to you, sir.
Thank you so much, Priyamali and Ganaka. First of all, I must thank the Sri Lanka College of Internal Medicine, our college, to give me this opportunity to talk to you about this fascinating topic. Now, first of all, I must tell you, I selected this topic as ECG interpretation beyond basics because I guess I'm talking to some knowledgeable people, maybe people who know more than me about ECGs with fresh knowledge. So the whole idea is, so I'm not going to talk about the basic ECG interpretation which we do to our medical students and to junior doctors, and to show you some interesting ECGs which we normally find in our day-to-day practice. And I thought it is important for you all as young clinicians, young consultants in the near future to diagnose these ECGs and either treat or refer to definitive treatment. Without taking much time, I'm going to start showing these ECGs. Actually, my preparation was to show you 20 ECGs, but then last minute I removed one ECG, so there will be 19 ECGs. So question number 8 is missing. It's not by a mistake, I purposefully did it. So as Dr. Priyamali mentioned, I guess all the participants are unmuted, especially the SRs, so you can communicate and you can ask questions, you can discuss. That will be very helpful for others also to know and share the knowledge. This is a learning exercise. So I would like to discuss with you all, and maybe I am wrong sometimes, so we can correct ourselves and move forward. So we'll start with, because I was asked to finish by 8 o'clock. Therefore, without much delay, I will start showing you the ECGs. please talk. It is not a issue. If you have questions also, if you want to comment also, please do. I hope this will work. Okay. The first question is patient presented with atypical chest pain. Identify the ECG abnormality. Anyone who like to answer the question? Can you identify the abnormality found in ECG? Okay, now this problem I find at least once a month. That is because taking ECGs in a hurry, sometimes they don't attach the limb leads correctly, right? So you can see when you take an ECG to your hand, one of the first things I look at is the P wave in L1, and also the same change will be there in P wave in AVL. As soon as I see that, I look at the R wave progression. So if the R wave progression is normal and the P wave is negative in the L1 and AVL, that is reversal of limb lead, reversal of the left and right limb leads, upper limb leads. So we call it mechanical dextrocardia, and often I find this, and sometimes these have been seen by doctors and the family doctors, and they also scare the patient and they come rushing. So always look for P wave inversion in L1 and AVL, and this is a ECG of mechanical dextrocardia. The way you should find is with the P wave inversion, there is normal R wave progression. So I hope you got it, right? But next I'll show you some other limb lead reversals which are less common and difficult to find. So not only the upper limb leads are reversed, or the left and right limb leads are reversed, sometimes lower limb leads also can get reversed. We occasionally see this. The way to identify is there will be a P inversion in the L3 with negative QRS complex. P inversion in the limb lead with negative QRS complex, as I have indicated there. And also, usually in a normal ECG, the P wave is best seen in the L2. That is why we normally take L2 as the rhythm strip. But when the left upper limb and left lower limb leads are reversed, the proper P wave or the bigger P wave is seen in L1 compared to the P wave in L2. So the two ways we can identify the limb lead reversal, the left upper limb to left lower limb, is P wave inversion and QRS complex inversion in L3, and P wave, bigger P wave in L1 than L2. The other possible limb lead reversal is reversal of right upper limb to right lower limb. The right lower limb is the earth, and that can be changed. All these things happen in reality, but these are very occasional. The way to identify is when you see a straight line, almost a straight line like asystole in L2. Look at the rhythm strip here. The L2 is it's like asystole. If you see this, and now this thing can happen commonly. That's why I wanted to show you, because you connect a patient to a monitor and reverse the right upper limb and right lower limb and put L2 as the rhythm shift, you will see a asystole. You might think that the patient has arrested and or even dead. So this is an other limb reversal. So please note, and there are things like that, but the commonest limb reversal what you see is reversal of upper limb leads, left upper limb and left lower limb. Second question. This patient presented with acute coronary syndrome. What is the abnormality? Can anyone answer? Strangely, no one. Can you all hear me actually? Priyamali or
Yes,
someone?
we can hear you. We can hear you.
You all can hear, no?
Yes,
I thought the senior
no,
registrar
and all
can't hear.
are unmuted. Everyone can talk.
Yeah, okay, please.
49 people.
All right. Now this is a real ECG that I have collected from my training. This patient was actually transferred from another hospital for us to put a ICD to consider for ICD implantation, because during acute coronary syndrome, suddenly the patient developed this ECG pattern. It looks like multifocal ventricular tachycardia or torsades pointis, as you can see. But actually, this is an artifact. Now, these A4 size ECGs, you know that all these four, like from top to bottom, is one QRS complex, is one heartbeat, because this is printed from one end to the other end. Although there are 4 rows, it won't print like 4 rows. As opposed to our normal ECG, the tape-like ECG, each beat is just one heartbeat, each QRS complex. So here, one QRS complex can be, one heartbeat can be seen in 4 QRS complexes. And if you know that, you will find that how can the L2 in this the rounded QRS, the area, the L2 is a normal QRS complex, and V3, V1, V2, and V3 are VT. It can't be, because it's same heartbeat. There can't be. It is not VT in one lead and L2 in another lead. So this is actually a motion artifact. Often we find this. Now we connect patients to telemetry and in the CCU. And morning the patient goes to the washroom and they start brushing teeth. And when the chest wall moves, when they brush teeth or something like that, and these rhythms appear. So this is a motion artifact. And all what we did was reassure the patient and send the patient back to the hospital. He was transferred. So the artifacts are there, and also find out there are other ECGs with muscle tremors and people with Parkinson's disease, people who are shivering, people who are anxious, all develop muscle twitches or muscle tremors. They are also reflex in the baseline. So sometimes you can see them as like fibrillatory waves or small spikes. So all those are motion artifacts. I hope you agree with that. This is another ECG. This patient presented with severe chest pain for 2 hours, profuse sweating and lightheadedness. What is the diagnosis? What is the diagnosis? I know you are not answering, so I'll tell you the answer. Of course, this is a
posterior inferior.
I'm sorry.
There's an acute chest elevation in the posterior as well as the inferior leads.
Yeah, I will.
And there's a complete heart block, Namal.
And the yes, a heart block. Yes.
yeah. Ganaka, you are not allowed to answer. I know you will find out. Yeah, this. Yeah, you are right. Thank you, Ganaka. Thank you very much. Because Yeah, it's an interesting ECG. Always when you see a inferior STEMI, look for conduction abnormalities. Gana is quite right? And this patient has an inferior STEMI. I don't like the word acute inferior because all the STEMIs are acute. And this patient has developed a complete AV block. So we need to treat both. We have to put perhaps a temporary pacemaker line and resuscitate the patient and do definitive treatment. Send for primary PCI or thrombolysis. Whether this patient has this is posterior infarction or reciprocal changes, I think there is an element of posterior infarction as well. So I think this is an interesting ECG where inferior STEMI plus complete AV block. Always look for conduction abnormality, not only complete AV block, even second degree or some AV block can occur. You know the blood supply, 60% of the time SA node is supplied by the right coronary artery, 90% of the time AV node is supplied by the right coronary artery. So it is very common with especially when the right coronary artery is dominant to develop conduction blocks with the inferior STEMI. Okay, question number 4. This elderly patient presented with recurrent episodes of loss of consciousness. What is the diagnosis? Sorry, there's a spelling mistake. What is the diagnosis? Okay, can answer. Yes.
Atrial fibrillation.
Okay. Yeah, you are right. I agree with you. There is atrial fibrillation. What is the heart rate like?
AF with fairly bradycardia.
Yeah, so the heart rate is, I think, less than 40, isn't it? It's in 30s, I guess. Right? So, what is the diagnosis? This patient actually has complete AV block with atrial fibrillation. That is why the rhythm is regular. The only instance, I guess, the atrial fibrillation becomes regular is when there is complete AV block. So when the rhythm is regular with fibrillatory waves in the baseline and bradycardia, profound bradycardia is complete AV block. Now you can see the red box, the severe bradycardia, but regular. And this is where you should have your either the divider, or you can take a piece of paper and see whether these are regular. And this patient has atrial fibrillation with complete AV block. Tell me if you don't agree also. There's a question. There's something in the chat box that is about all of you can join the discussion. This is by Priyamali. Okay, thank you.
I think I will ask them to talk rather than answer in the chat box.
Yes. Lakmal, you wanted to ask a question, Lakmal?
Yes, sir.
Lakmal Vitanage, yes.
If it is a complete heart block, the complexes appear narrow. Is it where is the origin then? Should be like broad complex if it is a complete heart block, isn't it, sir?
It's a good question, Lakmal. Thank you for asking that. Now the width of the QRS complex in complete AV block. I don't like the word heart block. We normally, the correct terminology is AV block, because the block is at the level of AV node or below. So if the block is at the AV node itself, the QRS complex tends to be narrower.
All right.
So as long as the the place where the block goes down along the His bundle, the QRS complex gets wider and the rhythm becomes unstable. So sometimes when we decide to put a temporary pacemaker also, we look at the width of the QRS complex. If it is become wider, so the likelihood that the patient will become a pause or a asystole is more. But if now there are patients with congenital complete AV blocks, where the QRS complexes are narrower. So those are stable. Sometimes they go on for years. Now children with congenital AV blocks, we observe them for years until they get younger, good pacemakers. So it's a good question.
Thank you, sir.
This patient with severe heart failure presented with dizziness and lightheadedness. What is the diagnosis? This patient with severe heart failure presented with dizziness and lightheadedness. What is the diagnosis? I thought this is an ECG, but the same ECG I showed to the medical students also. Now the salient point here, or the main feature, is tall and tented T waves, and also widened QRS complex. Okay? So it is not only in patients with renal failure. It's very common to see hyperkalemia is very common in patients with chronic heart failure also, because they are on various medications that can cause hyperkalemia. And usually the treatment for congestive cardiac failure is polypharmacy. And we try to give these medicines either maximum tolerable doses or the maximum recommended doses to the patients. ACE inhibitors, the ARBs, ARNIs, spironolactone, all, we don't combine all of them together, but either ACE inhibitors with spironolactone or others with spironolactone we give, and they present with. So remember the ECG changes of electrolyte abnormality, especially hyperkalemia and hypokalemia. Right? Now this slide shows you how the ECGs change with the serum levels of potassium. So usually the ECG levels start changing from about 2.8 millimoles per liter, and when the potassium levels lower, they develop QT prolongation, T inversion, ST segment depression, and all that. And likewise, when the potassium levels are higher, starting with tall tented T waves, then QRS complexes, and PR depression and inversion, and ultimately patient end up with sine waves and later asystole. So know about the management and all that I'm not going to discuss, but this is the ECG that you should never miss, the early signs of hyperkalemia. This 20-year-old female presented with sudden onset palpitations. What is the diagnosis?
Supraventricular tachycardia.
Yes. Yeah. Very good. I agree. Can anyone tell a bit more than that? Supraventricular tachycardia is correct. Supraventricular tachycardia, what is the, now anything that starts, any tachycardia that starts above the AV node, above the ventricular level is called supraventricular tachycardia. Okay, so this we commonly or loosely call as supraventricular tachycardia, but even atrial fibrillation or atrial flutter or multifocal atrial tachycardia, now this is actually called a nodal tachycardia, AV nodal tachycardia. nodal tachycardia. And there are two types of AV nodal tachycardia. One is called AVN cardia. Right? What is common? AVNRT or AVRT?
AVNRT.
AVNRT is common. It's about 80 to 90% of the time it's AVNRT. Now this is actually, I just want to show you. This is it's a nodal tachycardia, but AVRT type nodal tachycardia. Can you see the inverted P waves? That is how you identify AVRT tachycardia. Now this picture in the slide shows you how it actually happens. AVRT tachycardia, there is a re-entry pathway outside the AV node. Therefore, the P wave occurs after the QRS complexes and it is inverted. So you identify the AVRT tachycardia by inverted P waves, and I'll show you AVNRT type tachycardia. This is the common tachycardia you see on the ward when this type of people present with tachycardia. But actually, it is not very important to identify or differentiate AVRT from AVNRT because treatment is same. It is only important for the cardiac electrophysiologist to ablate. Then he knows exactly where the recurrent path is. Sometimes the AVNRT tachycardia, part of the AV node has a slow pathway and a fast pathway. So that part has to be ablated. In AVRT tachycardia, there is a recurrent pathway or an aberrant pathway outside the AV node. So for us, the treatment is same. We can give adenosine in both. We can give verapamil. We can do all the maneuvers like the maneuver, massage, eyeball massage, or whatever you want to do, you can do. Other. I was just checking the chat box. There's another message. Question number 7. This ECG was taken from a patient with anterior STEMI after thrombolysis with streptokinase. What is the diagnosis?
Idioventricular rhythm.
Very good. Yeah, thank you for that. This is idioventricular rhythm because you all need to know this. Why we need to know this? When you see the idioventricular rhythm, we should not try to treat that because the ventricles have lost conduction from the SA node, and the ventricular has its own rhythm. That is why it is called idioventricular rhythm. And after a while, it will get corrected. There are two such rhythms. This is actually the correct answer for this is accelerated idioventricular rhythm. There's a idioventricular rhythm also. How we define is when the heart rate is less than 40, it is idioventricular rhythm. But in this particular ECG, heart rate is more than 40. So this is actually accelerated idioventricular rhythm. I think I have put the answer also as idioventricular rhythm, but I'll tell you this is accelerated idioventricular rhythm. Now, when the heart rate is more than 120, we call it ventricular tachycardia. With these widened QRS complexes and QRS, the heart rate or ventricular rate more than 120 is ventricular tachycardia. Heart rate between 40 to 120 is accelerated idioventricular rhythm. So the correct answer, I think the correct answer is accelerated idioventricular rhythm. So if you see that, you leave it alone, provided the patient is hemodynamically stable, we should not give any medicines here because this might end up patient having asystole or progress to ventricular fibrillation. This is an ECG. Now all these ECGs are common, and when we treat these patients in our wards, you will time to time find these patients in the general medical ward. That's why I wanted to select these ECGs to show you. This is an ECG of an elderly male who presented with episodes of loss of consciousness. What do you find?
First degree heart block.
Okay, yes.
Triphasicular block.
Say it again.
Triphasicular block.
Yes, very good. Excellent. Now, what do you find here? We see the right bundle branch block. There's a positive and widened R wave, slightly bifid R wave in the V1, V2, and V3. So that is right bundle branch block. There's left axis deviation, and if you look at the S wave, it is also bifid in L2 and L1. So that is left anterior hemiblock, and also it's obvious that this patient has first degree AV block, right? So this is the triphasicular block. Very important to find out, because this is actually can progress into complete AV block, and also the patient can develop pulses and so on. So mainly complete AV block. So this is a triphasicular block ECG. This patient has right bundle branch block, left anterior hemiblock, and first degree AV block. Now, please read about triphasicular block. There are incomplete triphasicular blocks. What you just saw is an incomplete triphasicular block, and also complete triphasicular blocks. The patients can develop complete AV block and asystole. So if they are symptomatic, especially, they should have a permanent pacemaker implantation. Right? You can see the causes also. Now there are different types of trifascicular blocks. What you just saw was a bifascicular block and a first degree AV block, but also you can have a bifascicular block and second degree AV block, and also right bundle branch block can alternate in left anterior or left posterior hemiblocks. This ECG was taken from a cadet officer on recruitment. You know, I and Priyamali, we all work for KDU. Every year we recruit about 400, 500 cadets, but we assess about 5,000, 6,000 cadets. So they are medical assessments. This ECG was taken from a cadet officer on recruitment.
True Destrocardia.
Yeah, this is a true Destrocardia. Now we just showed, I didn't mention any about this there because I wanted you to identify. Yes, the P wave is inverted in L1 and L2, and look at the R wave progression. It's not there. The R wave progression is not there. So it used to be long ago that these people are not recruited to the army because their heart is on the other side. But then after a while, we explained to them that is a good thing, because if they aim at the heart, it will go through the lung only, because the heart is on the opposite side. So now we recruit these cadets to become military officers, irrespective of where their heart is. And this other important thing is to find out whether this patient has situs inversus or not. Now, these are the ways to identify true Destrocardia. Inverted P in L1 and AVL, and poor progression or opposite progression of we call it reverse progression of R wave. Okay, so don't miss that. At least do X-ray and see. This ECG was taken from a 30-year-old male when presented with chest tightness. Identify the abnormality. Can anyone tell me? That's a very interesting ECG. I have found this ECG twice in my lifetime, in the real lifetime, in the practice. Anyone? Yeah, Lakmal, you want to ask any question?
Is it Brugada?
I'm sorry?
Is it a Brugada pattern, sir?
In Brugada, you get a ST elevation in V1 and V2, isn't it? This is not Brugada. Actually, what has happened was, now you see in Sri Lanka, the hospitals have very good ECG recordings, but in many places, even in these leading private hospitals, the girls who just finish A-levels come and they are given like a 1 or 2 day training and they start taking ECGs. They're very enthusiastic, they work very hard, but sometimes they do certain mistakes. Now I showed you ECG of limb lead reversal, but what has happened here was, you know how to attach, we do in a physiology practical also to do ECGs. V1 is attached on the right side and then gradually goes to the left side, V1, V2, V3, V4. They have attached the leads at the correct place but reversed. So instead of attaching, they have attached the V6 to V1, V5 to V2, V3 in the right place, V4 to V4 to V3, V3 to V4, V2 to V5, and V1 to V6. So the complete reversal of chest leads. Right? That V1 is actually VC. You can interpret this ECG if you identify that issue. Because instead of looking at V6, you can look at V1 for V6, the exact same lead. Now this is on the other side, these two strips that I have put there. This is ECG. A patient brought to me that ECG was taken somewhere in Palutara. So I saw an identity reversal of this chest lead reversal or else some other abnormality. Sometimes they can come with the paper speed, different paper speeds, and the ECG looks very bradycardic, or else the voltage has been changed. This is the normal ECG, not to worry, but there's a small mistake in taking this ECG without blaming the other place also. These so this is a complete reversal of chest lead. This patient presented with progressive shortness of breath for 1 week. She has a disseminated breast carcinoma.
Pericardial effusion.
Very good. Excellent. There's a very good someone with a very soft voice, but a very good ECG knowledge. Good. So how do you identify pericardial effusion here? List out the abnormalities you see.
Electrical alternance.
Yes, there is sinus tachycardia. There is sinus tachycardia here. Heart rate is about 150, and small QRS complexes. If you look at the V5 and V6, they are small electrical alternats. So when those three things are, this is one of my patients, one patient I have aspirated in New Zealand, and I collected the ECG. This is about this ECG is about 18 years old now. I have shown that in several presentations. Typical electrical alternance, sinus tachycardia, and low voltage complex. This ECG was taken from a young male who had a road traffic accident. He has left-sided chest pain and shortness of breath. What is the diagnosis? Little difficult, but let's see. You need a bit of guessing also.
Possible pneumothorax causing small complexes.
Yes. Someone was. Yeah, you are right. Tell it loudly.
Pneumothorax causing small complexes.
Excellent. Excellent. Yeah. Now, what we find here is small QRS complex. Small QRS complexes, especially in the chest leads. When you see small QRS complexes, you have to see where the small QRS complexes are prominent, whether it is in the chest leads or whether they are in the limb leads. Here is both chest leads and limb leads. So this patient actually, because there's a catch, road traffic accident, left-sided chest pain and shortness of breath, low voltage QRS complexes due to left-sided pneumothorax. Very good. So know the low voltage ECG complexes. It could be pericardial, as we already saw, pericardial effusion, constrictive pericarditis, pneumopericardium. Pneumopericardium is common after pericardial effusion aspiration. Then pleural effusions, pneumothorax, like in this case, COPD, pulmonary edema, pneumomediastinum, then chest wall edema, obesity, massive myocardial infarctions because the muscle mass has lost, infiltrative cardiomyopathy, myocarditis, hypothyroidism, and so on. Now, some books say that like in COPD or emphysema, especially the limb lead QRS complexes are smaller, and they also have pulmonary hypertension. Therefore, sometimes some books say that if the P wave is taller than the QRS complex in the limb lead or L2, you can even diagnose COPD from the ECG. If the P wave in the L2 is taller than the QRS complex in L2, you can actually diagnose emphysema. So know about that, because right atrial dilatation is there from tall P wave. This ECG was taken from an elderly male who presented with episodes of dizziness. What is the diagnosis?
Multifocal atrial tachycardia.
Okay. What is the heart rate? Is there tachycardia here? So if there's no tachycardia, what is it?
It's wandering atrial pacemaker.
Excellent. Yes, this is a wandering atrial pacemaker rhythm. Right? The SA node is not firing. Therefore, there are several places in the atrial syncytium activated as pacemakers. So there is the definition is if the configuration of the P waves have more than 3 different types, you can diagnose wandering pacemaker rhythm. So this is a wandering atrial pacemaker rhythm. It's common among people who have chronic respiratory disease. And because this is actually a type of sick sinus syndrome, that is why the patient has episodes of dizziness. Wandering pacemaker rhythm. You can see different types of P waves. And it is another cause of irregular pulse. This is how it occurs. The heart rate or the ventricular rate is 100 to 60 to 100 within the normal range. Right? The pacemaker, there are few other pacemakers and must have 3 different P wave configurations. Usually the rhythm is irregular. I'm sure you know how the heart rate is calculated when the rhythm is irregular. You take 15 or 30 large squares and count the QRS complexes and multiply by 10, right? You know that. This ECG was taken from a COPD patient who presented with palpitations for 2 days. What is the diagnosis? Anyone?
Atrial tachycardia.
Multifocal
Okay, atrial tachycardia, I agree.
Multifocal atrial tachycardia.
I'm sorry?
Multifocal atrial tachycardia.
That is right. Yes. Yeah, it is a type of atrial tachycardia. This is multifocal atrial tachycardia. Actually, if you look at those arrows, you can see different types of P waves. So it starts from different sides of the atrial syncytium. This is a ECG of multifocal atrial tachycardia. Multifocal atrial tachycardia. So in this picture, you can see multiple sides. So they take their turns and fire. Right? So clinically, it's very difficult to differentiate atrial fibrillation, atrial flutter with variable block, and multifocal atrial tachycardia. Only by doing an ECG we can differentiate. Right? There the SA node is not pacing. The SA node is sick. This is both wandering pacemaker and multifocal atrial tachycardia are common among patients with chronic respiratory diseases like COPD. Right? So SA node is sick. Several foci of atrial pacemakers, at least 3 or more different shaped P waves, and the heart rate or the ventricular rate should be more than 100. That is how we call it tachycardia. And also, you are not going to do any more MCQs. There are here the P waves, the PR intervals can vary, the RR intervals can vary, as well as the PP intervals can vary. This 26-year-old male presented with intermittent palpitation. What is the diagnosis? Anyone?
Brugada type A.
That's right. This is Brugada. Brugada syndrome. You spot the ST elevation in V1 and V2. right? The commonest type, you see, I didn't want to put in the history that this patient or resuscitated from a cardiac arrest or something like that. Then without the ECG, you will tell. That's why I just put intermittent palpitations for you to identify the abnormality from the ECG. Quite rightly, you did it. Very good. And this is a Brugada syndrome. You can see that the two types, right? This is actually type 1, right? Type 2, there are 3 and 4 types as well, but common ones are type 1 and type 2. Type 2 has a saddleback type ST elevation, right? As you can see in this picture. But the type 1, there is an enlargement on the left-hand side of your screen as well. That is type 1 Brugada syndrome. So all what you need to do is to refer to the cardiac electrophysiologist. They will do further investigations and like VT studies and all that to decide whether this patient needs the ICD. So very good that you spotted Brugada syndrome here. These are the two types. Remember the definitions. ST elevation should be more than 2 millimeters, and there's a downsloping ST segment and inverted T wave, like what we saw here in our ECG, right? Downsloping ST and T inversion. Then type 2 has ST elevation more than 2 millimeters, saddleback ST T wave configuration, upright or biphasic T wave. So T wave is inverted in type 1 and upward, not inverted in type 2. Okay. This elderly patient with congestive cardiac failure presented lightheadedness. And I think I reviewed a case report also written by one of you about bidirectional ventricular tachycardia in a myocarditis patient. So that is also a cause, but the commonest cause is digoxin toxicity. So remember, there are different types of ventricular tachycardia: multifocal ventricular tachycardia, and also bidirectional ventricular tachycardia. So that can be as a result of any of these causes mentioned in this slide. This is an ECG of a medical student. If both parents have hypertension, what is your opinion? Often they do ECGs and bring to you. Anyone? Yes?
How come like ECG?
How come? Can he have hypertension? Why you say how come? You think this patient has LVH, isn't it?
LVH, yes, sir.
Yeah. Now this is a common mistake most of us make, and sometimes they are referred for echoes also, thinking that they have LVH. Now remember that the learning point here is don't diagnose LVH based only on electrical criteria. Right? This student has tall R waves in V4, V5, and also S waves in V2 and V3. So if you apply the electrical criteria, yes, this patient is fulfilling LVH criteria, but don't diagnose it without LV strain pattern. So this ECG is actually normal ECG. Right? Increased voltage QRS complex are normal for adolescents because they are young. They have very good electrical activity, and also they are usually thin. You just attach the lead just on top of their heart. Right? So they tend to have tall R waves because they are very healthy. They have very healthy hearts with a lot of electrical activity. That is not because of LVH. If you want to diagnose LVH, it has to be like that. There has to be a reverse tick pattern or a LV strain pattern. So we call two type of criteria. One is called the voltage criteria. Other one is called the repolarization criteria. If you combine both, your sensitivity, your specificity of LVH diagnosis goes up. Right? So here, if you apply the voltage criteria with the repolarization criteria, you can diagnose. This is a typical LVH. And also look at the QRS complexes, they are little wider. When there is LVH, the QRS complex also become not as wide as like an ectopic or ventricular tachycardia, but slightly wider and left ventricular strain pattern. That is how you diagnose. But know about these are the two types of criteria. There is electrical criteria, as you know. If you take how I remember is L5, so V5 or V6, R waves more than 27, or else R wave in V5 or V6 with S plus S in V1 or V2 more than 35. That is called Sokolov criteria, Sokolov and Leon criteria. And there are Framingham criteria. And also this Rom-Milton and Estes criteria is a scoring system where they try to include the repolarization criteria as well. So remember, don't diagnose LVH based on electrical criteria alone. Always look for strain pattern as well. Question 19. This patient presented with central chest pain for 3 hours and sweating. What is the diagnosis?
True posterior infarction.
Correct. Yes, very good. This is a true posterior infarction. Right? You can also call it a posterior STEMI, although there is no ST elevation. If you want to show ST elevation, you can take posteriorly. So people tend to miss this. That is why I want to show you and treat as non-STEMI. This is actually a STEMI, but I don't know whether you treat it as an acute coronary syndrome or non-STEMI or a STEMI, whether it makes any difference, because the usual the repolarization, thrombolysis trials, fibrinolysis trials are for anterior and inferior STEMIs. I don't think they had include much of posterior STEMIs, but don't miss it, because this is actually a STEMI. Now, this is, if you look at the picture on your left side, that is a mirror image. If you take it other way around, you can see the ST elevation. Right? If you want to demonstrate, you can take posterior leads and demonstrate it. It's not necessary. If you see this, this is true posterior STEMI. Okay, the last slide. Last question. This ECG was taken for preoperative assessment. What is your opinion? I would say that is the most difficult ECG to diagnose.
Sinus rhythm.
I'm sorry?
Sinus rhythm, sir.
Yes, this is normal ECG. To tell ECG normal, you have to know a lot about ECG. Right? Often we find, I'm sure you also have seen, people go to their family doctors, they do ECGs, and they are told, make a podi avulak tiyena. Right? And actually the ECGs are normal. Now what I tell my patients are that you know, if like they normally come with their bystander or their relative, if all of us did ECG, 3 of us or 4 of us did ECGs, they all can be normal, but they don't all look the same. Right? There are books written on ECG, normal ECG, books written on normal ECG. So how can there be a book if it has only one page if it is a normal ECG, all the others are abnormal? It's not like that. There are a lot of normal variants. Therefore, you need to have experience in reading ECGs to identify normal ECG. Now, this is a straightforward normal ECG, but not many people can say that it is a normal ECG because to say that they have to have a very good knowledge, right? So that was the last ECG I had to see. I was threatened to stop in 1 hour. So I think I stopped exactly in 1 hour, but we can discuss anything if you want, if I have 1 or 2 minutes. Thank you very much. Jamali?
Yes, you all can ask any questions from Professor Wijesinghe. We have a few minutes.
So I have a question.
Yes.
So we usually during our practice we see commonly this hyperkalemia. As the book says, the level of calcium, the point of calcium gluconate to be given once the potassium is more than 6.5 and the hyperkalemic changes. But often we do practice even before it reaches 6.5, we usually give calcium gluconate since we can't take a risk. So what is your recommendation for giving calcium gluconate? At which point we should give it?
The recommendation is to straight away do a ECG. If there are ECG abnormalities indicating the cardiac involvement, to give calcium gluconate. I mean, we all know that. But giving a calcium gluconate IV bolus it doesn't cause any harm. So if you are in a doubt, you can always give that and see. But the correct indication for calcium gluconate is cardiac involvement of hyperkalemia as indicated by ECG changes. But if anyone gives without ECG changes, I don't find fault with it.
Sir, can you please explain the ECG number 2, sir?
I'm sorry?
Number 2 ECG, can you please explain it again, sir?
We'll try to go back there. I lost my slides. Someone is going to I'll share again. I think something happened. Can you all see the slides? I can't see my slides.
No, we can't see.
I'll stop the sharing and I'll do it again. I lost the slides. I'm trying to get back. I think I'm getting call from the organizer. Hello, Disha. Oh. Oh. Hari. Can you see the slides now?
Yes.
Can you, PML, can you hear me?
Yes, yes.
Okay. Now we can
Can
see.
you see the slides?
Yeah,
Yes.
we can see the slide. I think because when you go to the presentation mode, it vanishes. Why don't you do it in the same?
Yeah, I'll do like that. Yeah, sorry. Okay, I hope you can see the slides now. I can advance it. I can understand. So the second slide is this one.
Yes.
Now what I said was, now think about the two types of ECGs we take. One is this tape-like thing. It's a tape. So each QRS complex is one heartbeat. Okay. So one advantage of having this tape-like thing is you can see several, about 50, 60 heartbeats in that ECG. Now, when you take this A4 size ECG, we can take only 12 to 15 heartbeats because the whole one line, if you look at this left-hand corner of this ECG, I don't know how to, like left-hand corner of the ECG, this L1, L2, L3, and L2 again. The ECG QRS complexes are one heartbeat. One heartbeat. So my what I say is, now if you look at where this arrhythmia like ECG is, that V1, V2, V3, and the L2 is all one heartbeat. How can you have a arrhythmia and a normal QRS complex in the same heartbeat? So that is one way we identify that. Now here, this V1, V2, V3, and if you carefully look at it, the QRS complex can be seen in between those motion artifacts. That is why I said it is not an arrhythmia, it's a motion artifact that is commonly seen in CCUs. And this is also seen in Parkinson's patients and very anxious patients. You can see. I hope you understand that. Any other question?
So I have one question.
Yes.
We are seeing that with inferior MI, various kind of heart blocks, as we have seen one with the complete heart block. So sometimes we tend, because we have less chance to get the TPM or some. We usually give atropine when they're having ready, but we try to give thrombolyze as soon as possible. And is that okay, or whether the patient need to be stabilized first?
If the heart rate is very low, better to stabilize the patient first. And the other options are, you said you give atropine and setting up isoprenylate drips. Some of these are like off-label. And also, if you have a defibrillator, you can start external pacing. And thrombolize the patient. You have to take a chance and thrombolize the patient, because one way is to re-establish the blood flow to the AV node.
Okay. Thank you, sir.
So, but if the patient is hemodynamically unstable, you have to first resuscitate the patient.
Thank you, sir.
Yes. Some other thing in the chat box. How to identify motion artifact in a long strip? Again, yeah, it's possible. You know, you have to look at the baseline. And with experience, you can. I mean, we often identify muscle twitches. Now, yeah, it's a good question, because if you have this type of ECG is easy, but even in a long strip, you can still identify. One other question. No, the same question. So in the absence of questions, Pemari, I think we can call it a day. Isn't it?
Yeah. Yes. Thank you very much, Professor Namal, for this very interesting and interactive discussion. And you refresh our knowledge and you taught us new things. Thank you very much for that. And I would like to thank Dr. Ganaka Senaratne, who is behind us, like giving advices and encouraging us for these things. And our senior registrars who are participating very actively, and the other trainees. And I would like to thank Gates Pharma for their sponsorship, and Mr. Dishan Fernando for IT support. So have a very good night. We'll wind up.
Thank you, Priyamali. Thank you, Namal. Wonderful talk.
Okay, thank you guys. Thank you for your participation and the discussion, especially the few senior registers who continuously discussed and contributed. All the best for you all, and wish you all the best for your all the endeavors. Thank you very much again.
Thank you, sir.